Well, no.
And Amy Portman. I know I broke my
What'd you do with your old bag?
You got a card at the end of the thing, that'd be great. Or don't worry about it.
I don't have them yet, but I'll write it out.
No, I'll wait.
The mic, just the mic. Well, it went down. We'll see what it counts. Yes, we do.
So it'll work for them over there. I just want to make sure.
It'll work as well as it works for people at home. It has been good, but that's what's available.
Yeah. Just asking.
Oh yeah, thank you.
Thank you.
No,
I appreciate the overflow.
I wasn't meaning that.
I hope you were.
That's mine. I'll get it out of there.
I don't know if it's time yet, so.
Okay, you got that? Now we're looking at the live stream coming online. Should be coming on. Okay, live stream. Let's do it. Bam. There it is. Audio. Pretty good. Lots of noise. Could you talk into that? It's picking up audio from us. It's not doing it.
Picking it up from your laptop. Go back to your audio source. Got the camera selected.
Yeah, I didn't.
The camera's still on. Go back in there and now,
Okay.
unselect now. Go ahead and put it on.
I can hear this conversation. It's coming.
Is there another mic on?
I'm still.
You gotta have another microphone.
Oh, another microphone somewhere. This one? How do I turn it off? Oh, no? Why not disable that? It's sharp, fine, yeah.
The microphone.
This? Getting better.
Okay. All right. We'd like to get started here on time. I think we have a couple of representatives that are getting seated
Started.
at the kind of on the edges of the table there. We'll get everybody down. Okay. Okay. I'd like to welcome everybody here for our first official oversight meeting. A couple of things we need to clear up as we move forward through the agenda. We have a presentation by the department. We'll be going over the quarterly report. They will be taking they'll move through it, mention the highlights of it. It should take about half or maybe just a little more of the time allotted for the DHS to make that report. The balance of the time will be open for questioning from the members of the committee. If there is time at the end of the allotted time set aside, other members of the legislature who have joined us at the table are welcome to ask questions. But I think we need to allow the members of the committee first to answer their question, to ask questions. The same will apply when we move later on in the program with the discussion and committee discussion with MCOs, and also at the time when we talk about electronic billing versus paper billing, where managed care and DHS will be at the end of the table. Members of the committee ask their questions first, and those not members of the committee are welcome to ask questions if time allows. Any questions? Okay. Well, Madam Co-Chair, I call this meeting to order, and I have a few remarks to make at the beginning, and I assume that you also have some opening remarks. So I want to take a minute and talk about the work of this committee first. We are 4 months into a new way of managing our Medicaid program, and we've had a few hiccups along the way. Transitions are hard, and we know we'd encountered some issues. However, last session, we took the opportunity that was given to us by this transition and implemented one of the nation's most robust Medicaid oversight plans. This will allow us to do what we need to do, and that is to ensure Iowa's most vulnerable citizens have quality health care and are moving toward a path of wellness. This committee exists for 2 reasons. First, to ensure that patients' needs are met and they are receiving the care appropriate to the level of services. Second, it is to ensure that the managed care organizations are held accountable. We have entrusted these MCOs with millions of tax dollars and expect them to fulfill their contractual obligations and improve Medicaid enrollees' health. If they do not meet the necessary benchmarks, they will not get their 2% of the contract that's been set aside. If they do not meet their contractual obligations, there will be monetary sanctions against those MCOs. If changes need to be made to the program to improve issues that have been identified in Medicaid, we will do what needs to be done to protect Iowans. We now have more data on the Medicaid program than we have ever had in the past. Making this data available to Iowans will allow us to have a much better understanding of how the program works, what Medicaid does well, and what areas need improving. We need to take this opportunity and learn about Medicaid program and make sure the program is workable and sustainable. The time for partisanship is over. Now is the time to ensure that Iowans are moving on a path toward wellness. Thank you.
I'll share with the smaller one here. Thank you, Representative Heaton. I appreciate those comments. When Governor Branstad announced his plans to hand over the administration of Iowa Medicaid to an out-of-state for-profit companies, I was skeptical. Medicaid provides care for 1 in 6 Iowans. That's more than 500,000 people. And Medicaid is the health care safety net every Iowan family can depend on when faced with long-term medical expenses. Medicaid services are provided by tens of thousands of Iowa workers and hundreds of Iowa businesses. Clearly, any changes to Iowa Medicaid needed to be changed carefully and thought out in advance. Governor Branstad disagreed and rushed the process. He wanted to privatize Medicaid and do it faster and more completely than any other state ever has. Iowans were promised Medicaid privatization would improve health care and reduce costs. Neither has happened. Instead, Iowans are being denied health care, communities are losing health care providers, and Iowans are losing their jobs. I attended this morning's Medicaid listening post at the State House. I've attended similar local meetings all across the state. I've talked with Iowans in tears as they describe fighting to protect the health care of their disabled family members. I've listened to social workers describe the maze of bureaucratic red tape and confusion now preventing them from helping Iowans in need. I've also talked with doctors, home health care workers, social workers, and nursing home administrators. And I've read the results of the recent survey of those health care providers, which revealed 90% say their administrative costs have increased. 80% say that more health care claims are being denied. 79% of providers say they are not getting paid on time. 66% say they are being reimbursed at rates lower than their contracted rates. 61% say the quality of service they can provide has been reduced. 46% have or plan to cut services, and 28% have taken out loans or will be paid. At previous meetings of this Legislative Oversight Committee, managed care organizations and the Branstad administration painted a very rosy picture of Medicaid privatization. Those rosy pictures have little to do with reality. Here's the reality we are now seeing. If privatized Medicaid is a three-legged stool of patients, providers, and administrators, then all three legs are broken. Patients and their families are exasperated, desperate, furious, and sometimes all at the same time. Providers are not being paid, have to hire bookkeepers and lay off caregivers, and are cutting back, if not actually closing their doors to Medicaid members. And last week, we learned that the MCOs are losing large sums of money. We have to understand that the Branstad administration is on a course to create more state dollars and less health care to Americans. These are factors to which we must pay attention because everyone is paying for the governor's gamble. Privatized Medicaid is a three-legged stool with broken legs. And today we need the administration to tell us how they plan to fix that broken stool. I'm particularly impressed with Representative Heaton's comments that he's going to look at changes, and as we've heard in the meeting before, there are many ideas on how to make that happen. So with that, I would let you take on the meeting.
Well, first of all, I'd like to recognize members of the legislature who have joined us today. We have Representative Spade and Winkler who joined us at the table today. And we also have Senator Garrett with us today. Representative Anderson, I'm sorry, you snuck in on me. I got a blind spot right here. And Senator Johnson in the room?
Yeah, you bet.
Okay, Senator David Johnson joins us.
And Representative Brown Powers.
Brown Powers.
Senator Brown Powers is here. Representative Brown Powers is here. Should have had a sign-in list.
Right?
Well, anyway, let's move on. The first part of our meeting today will be presentation by DHS. We're going to cover the Iowa Health Link quarter results. Let's see what's been going on out there. So if the department will approach the table, we have you come up. Members of the committee, you all have the Okay, well, welcome.
Thank you. Members of the Oversight Committee. The Department of Human Services takes responsibility for this oversight very, very seriously. And we're pleased to be able to present the first quarter report. I don't know that I believe it presents a rosy picture. I think it presents the facts as we know them, and some data that we have that we'll be able to build on. If we took a step back, similar to what Representative Heaton said, that the job of all systems and evaluation is, are they advancing quality, are they advancing access, and are they affordable? We'll be focusing on, as we move forward in this effort, the improvement of client outcomes and the goal of a predictable and sustainable Title 19 program. The role of oversight is pretty simple. While it's a complex problem, a complex process, the real question that any oversight process should be working to answer is, are we meeting these needs? And does our process, wherever we are in transition, lend itself to decisions around adjustments in the program, mid-course corrections, or things that we can be doing to enhance the meeting of those goals? We believe this process needs to be as transparent as possible. That's why meetings like this, information will be presenting and have been and will be presented across the state and to the many committees that are involved in this process. We'll try to make this information understandable to all. So accountability, I think, is critical. From a management perspective, we're committed to continuous improvement. That means that we need to identify areas where we can continue to improve the program and move forward, identifying areas where we can strengthen and make changes. We're in the front end of a transition. This report will focus more on process because that's really where we are in our transition, is on the front end. As we move on, we'll work harder and harder to present results regarding outcomes. So as we step forward, let me take just a second to thank the providers across the state of Iowa. As we've been wrestling through the administrative and billing issues, trying to
Director Palmer, get a little closer to the microphone.
I'm sorry.
They're having a little trouble hearing.
Okay, thank you. Let me repeat. Okay, better? Okay, well, I'll just repeat the last sentence. I want to thank the providers across the state of Iowa who, through all the difficulties that we were having in making sure that we get some of the administrative and some of the billing issues corrected, they continue to provide services. Services are being provided, and it's because of the commitment of the providers. And so I just want to emphasize them as carrying on their duties, and people are continuing to be served. I believe that we'll continue to work through issues together. We'll make corrections, and I think a strong oversight process is one that is very important in keeping the momentum of continuous improvement. With that, I'll turn it over to Mickey, but our primary part of this program is to present the first 3 months of data. Thank you.
Thank you, Director Palmer. Thank you, Director Palmer. Again, I want to thank you as well for the opportunity. And there you go. Okay, we got that. There you go. So again, I want to echo what the director said. I do want to thank the providers for assisting with our transition and continuing to work cooperatively with us. It is through that cooperation that we are in a continuous improvement to work collaboratively with them to ensure that our members get served. Again, today we are pleased to report on the quarterly report, and I'll be turning that over to Liz Matney, the Bureau Chief of Managed Care. Key are the key goals that Director Palmer has outlined. One is to improve quality and patient access to care, to promote patient accountability, as well as to create a sustainable Medicaid budget. We were here about a month ago. We walked you through our first monthly report, and that report gave you some basic claims data and participation in terms of our populations. What the report is, along with feedback from our association members, we have now, as of last week, launched our provider trainings. And key to those provider trainings is that we are in 11 cities. And in that training, we have 2 sessions in the morning and in the afternoon. The morning session is dedicated to our medical providers. The afternoon sessions are dedicated to our long-term service providers. And within that training, we are in collaboration with our MCOs. Our MCOs are there. And after those training sessions, if there are individual provider questions, the MCOs are there as well. Important to emphasize in that training is that we have standardized billing forms. We had them prior to launching with the MCOs, that all of our provider types are paid utilizing the same standardized claims forms that we use in our fee-for-service, as well as understanding and learning out how to fill those forms out and the information on those forms, and to learn and become educated on our prepay edits. As we move forward, we will continue to work with our providers and our MCOs on that training and that training initiative. Also, as Director Palmer also emphasized, oversight is why we are here today. Oversight is very important to us. We take that, and I take that job very seriously, to ensure that we are managing the managed care transition and its programs. It is key to the success of this program. You'll see in this report today that there is robust information that aligns with the legislation that was passed last year in oversight. But in addition to that, and it will be clearly indicated in our report, there is additional information that we are asking for, and those are to look at healthcare outcomes. Things that we are tracking in that arena are timely submission of claims, the reason for claims denials, our case management ratios, provider reimbursement, as well as prior authorizations, and that those are broken down between our pharmacy and our medical services. It's important to note that this is our first quarterly report, so as we move further on, we will have additional reports that will provide us with claims analysis and analysis to look at trends, so we can continue to enhance our program and move forward. Finally, and in addition to that, you'll learn today that yes, we do have sanctions that are built into our managed care program. It was reported earlier this month that we hadn't implemented those sanctions. There was no formal waiver of not implementing those sanctions. We moved forward in the first 2 months with our MCOs to work in collaboration to stand up with them and to work with them to address issues and concerns with contract compliance. Those sanctions, as you'll learn more today, will include everything from a written warning all the way up to including a termination of a contract based upon what we find. And we are now moving in a phase towards more robust oversight and management, and we'll use those sanctions accordingly as we go forward in this process. And with that information, I'd like to turn it over to Liz Matney, the Bureau Chief, to review the quarterly report.
Thank you very much, Mickey. Thank you, everyone, for having me here today to walk through the report. Obviously, it's a 60-page report. There's a lot of data elements in it, so I do want to take advantage of this opportunity to talk through some of the nuances of that data. As Representative Heaton mentioned earlier, this is the first report of its kind for Iowa Medicaid. It's the first time that we have published a comprehensive set of oversight and program management data for the Medicaid program. The data in this report still is dependent on some claims data coming in. So as the quarters move through, we will find some of those measures adjusting as we have more data at our disposal. Also, just as a note, that this data serves as a jumping off point for further investigation for the department. So there might be areas in which this just gives us a trigger or a key indicator that further analysis needs to be done, which is what we're doing in-house at Iowa Medicaid. As I said earlier, over time, this data is going to become more robust, and as we have other sources of validation at our disposal, we'll be able to make sure that the data that the managed care organizations report to us is accurate, and also be able to put together some additional analysis from our perspective that can either corroborate or dispute that data. In the transition to managed care, we've had multiple conversations with the Centers for Medicare and Medicaid Services about the process of getting data from managed care organizations, and they have emphasized that this process does take time. There's a process involved in which the state and the managed care organizations have to fully put their systems together so that we're able to receive data. And then once we do receive that data, there will be an additional period of time where we're validating that data as well. So this is an ongoing, continuous quality improvement process. We'll continue to see the meaningfulness of these reports increase over time. By the way, while I'm going through the reports, if there's any way that you want me to speed up or slow down, just let me know. Okay.
We just like to, have enough time at the end to be able to ask questions. That's what we're looking for. Okay?
Absolutely.
You're 10 minutes into your presentation.
All right, speed it up. Okay, so I'm going to skip over a lot of the demographic information. I think you can absorb that on your own time. We'll skip over to our population reports, which start on page 8. Now, I'm not going to walk through each one of the population reports. I'm just going to touch high level on some of those points. So the average aggregate cost per member per month is based on claims data. And like I said earlier, not all of the claims data is in for that reporting period. Providers actually have 180 days to submit their claims into the managed care organization. So we do have a bit of a lag. And then this also doesn't include any type of claims reprocessing that needs to be done by the managed care organizations for things like 1% increase in rates or the change to home health rates for LUPA or any type of nursing facility adjustments that need to take place. So this data is a point in time pull and we expect it to change. It's important to note that that will change. Also, I did want to note that the differences between the plans and their average aggregate cost per member per month can be attributed in at least part to their enrollment. So, for example, one managed care organization could have a greater number of members who need high-cost services, and that could be reflected and potentially skew some of their average aggregate cost reporting. So another item that I'd like to touch on is the members assigned to a healthcare coordinator. Now, it's important to note that prior to the transition to managed care, you'll see this on page 9, prior to the transition to managed care, this service was largely unavailable unless a member had a catastrophic health crisis in which they needed a case manager to help them navigate those services. So in requiring this for a number of disease management programs in our contract, we see this as a huge benefit to our membership in over the long haul, making sure that we are increasing member health outcomes and preventing or exacerbating health care situations. Also, we'll see fluctuations in this data just naturally. We don't anticipate 100% of members being assigned to a healthcare coordinator. It really is reserved for those members that really need it. They have those chronic, ongoing healthcare conditions. But members may not be assigned to a healthcare coordinator for the entire tenure of their enrollment with the managed care organization. So the healthcare coordination team will be working with that member to ensure that they have holistic care coordination across the healthcare systems, but also giving them the tools to be able to manage that themselves long term. At the bottom of page 9, you'll see the percentage and number of members receiving initial health risk assessments timely. I want to also note that prior to managed care, health risk assessments were not required for 100% of the Medicaid population. It was a healthy behavior that Iowa Health and Wellness members could access to get a premium reduction, but it was not available to every single member. So again, this will be a big program add for the members of our Medicaid program. All right, so moving on to page 13, we have the number of community-based case manager contacts. So the members served, if you look back, we're in the special needs population reporting. If you look back to page 12, you'll see the adult members served for each one of the managed care organizations within this population. I want to note that this is not directly correlated to the number of contacts that are required, that there is a mix of facility-based versus community-based members within those member-served numbers. So, and there's differing contact thresholds for each one of those populations. For example, For the community-based members that are receiving HCBS or rehabilitation services, we require 3 contacts per quarter, whereas with the facilities, we only require 1. So there has to be some type of weighted balance there, and we're looking into a way for the next quarter, a way to report that so you can more easily tie those numbers together. I do want to also note that prior to managed care, while this was a requirement for our HCBS waivers, that they had those 3 contacts per quarter, we didn't actively pull that information on a regular basis, so we don't have that comparison available immediately. I also did want to note that, as you might recall, community-based case management was not a service for members that were in a facility. They might have received social work services within the facility, but they didn't have a case manager assigned to them to overall manage their health care. So again, we see this as a program ad. Moving on to page 14, you'll see the community-based case manager ratios that we have been reporting to the Centers for Medicare and Medicaid Services. We have this broken out for each one of the programs that would be falling within the special needs population reporting, and then you'll find those ratios throughout the other population reports as well. As you can tell, the member to case manager ratios reported right now are pretty low. Part of that could have to do with the fact that we have all of the managed care organizations leveraging external case management agencies right now. So there could be a higher number of case managers available to each member. We expect these numbers to go up over time as we transition the members entirely over to the community-based case management system. While the department only has explicit rules for case management to member ratios for the ID and BI waiver, which is 45 members to 1 case manager, we don't actually have explicit ratio standards for the other waivers. But we do have contract standards built in for the community-based case management function, which we expect the managed care organizations to adhere to completely and adjust those ratios in order to meet those standards. All right, I'm going to shift on through the remaining pieces of the population report onto page 25, which is where we start the consumer protections and supports reporting. For these particular reports, I do want to note that the department prior to the transition to managed care did not have an actual grievance process within the department. While we did accept any type of member complaint and we would look into it, we didn't track it the same way that we're expecting the managed care organizations to track it, and we had no time frames for resolution. On the other hand, we've always had the administrative appeal process, which we will continue to have. But those are the process that the managed care organization has for appeals is slightly different than the one that we have within the administrative law. So they're not directly comparable, but we are making sure that they're resolving things timely. And when you look through this data, you will see that they are meeting those thresholds. Again, like I mentioned earlier, this data is really a springboard for us to dig in deeper. So one of the things that we all are also looking into and determining ways to report out to you is the nature of those grievances and appeals so that we can start tracking and identifying any type of systemic issues or trends over time. Moving on to page 27, wanted to explain a little bit of the critical incident data that you're seeing here. Now this data is only reported by providers and case managers for individuals who are on an HCBS waiver or who are in the habilitation program. This does not represent any incidents that are reported to the Department of Inspections and Appeals for those members that are in facilities. So a critical incident within the Iowa Medicaid program for the HCBS and habilitation members includes a physical injury that requires medical attention, emergency mental health treatment, death, law enforcement intervention, medication errors resulting in physical injury, law enforcement intervention, mental health intervention, member elopement, meaning the member is missing, reported child or dependent adult abuse. So we don't have an actual contract standard for what is right or wrong related to critical incidents. Again, it's a springboard for digging in more. A high number of incidents could be reflective of the enrollment that each one of the managed care organizations have. If one managed care organization has the bulk of the HCBS waiver members or particularly high-risk members, you would expect to see a higher number of critical incidents for that managed care organization. Or if they have better oversight or expectations for the providers to submit those critical incidents, you also might see a higher number. But again, it's a springboard for us to investigate deeper into the nature of those incidents and what they're doing to follow up with those incidents. On page 28, we start with service plans and level of care, timeliness completion. So if you recall, the department earlier this year extended out all of the HCBS service plans out until the end of July, out to July 31st. So technically between April 1st and July 31st, there were no service plan updates required. So that timeliness standard was not applicable to that time period, but we certainly will be monitoring that and reporting that for Q2. For level of care completed timely, the data that was reported does not meet the benchmark that's found within the contract. However, we did discover that there were some issues with the data that the department was reporting to the managed care organizations. There were some incorrect reassessment dates in that data. There was some duplicative data. There's also data in that for level of care assessments that were due when they were already being initiated and completed. So due to that, we have some additional data reconciliation to do to make sure that the data that they reported is actually reflective of their performance and that we're not seeing that perhaps they're including more level of care assessments in that calculation than is really necessary. Moving on to page 29, we have our helpline metrics for member helpline, provider helpline, and pharmacy helpline. All of the managed care organizations are meeting those standards. The department also continues to do secret shopper calls. As you will note, these are really just process standards for how well the managed care organization is answering the phone. We also want to make sure that we're monitoring very closely the managed care organization helpline soft skills and their ability to consistently and accurately answer questions that the members and providers have. So all of our secret shopper questions are updated on a regular basis. We glean areas where potentially there are situations in which the managed care organizations are not reporting things accurately or able to quickly get information to the members and providers. So we're leveraging anytime we hear a complaint from our own call center, from one of you, from the member or provider themselves, we make sure that we incorporate that into our questions that we ask as part of the secret shopper process. On page 31, we get into claims payment. Now we have broken out claims payment between the medical and pharmacy because there are very key differences in the way that those do flow through the system. First of all, the pharmacy claims flow through a real-time point-of-sale system. So those pay out pretty rapidly, whereas the medical claims payments might take some time to process and to do some additional research in order to make sure that all of the necessary information is there. When you look at the medical claims payment timeliness standard, you do see that for the standard of 99.5% of clean claims paid or denied within 21 days, Amerigroup has not met that, and we are taking remedies for that. Did want to note some definitions here. Clean claims means that the claim has all of the necessary information on the form to be able to pay that claim out. Additionally, a suspended claim is a claim that's pended for internal review to determine potentially medical necessity, or to work with the provider to make sure that all of the necessary elements are there so they can make the determination of whether it should be paid or denied. And then a denied claim is a claim where there's several different reasons for which a claim can be denied, but basically there's some flaw within the claim for which service or reimbursement should not be made. So it's important to note that this is a function of a prepay edit that goes through, make sure that there's not something programmatically wrong with the way that they're billing for this. This is a major program integrity tool to avoid the potential of claims being reimbursed that are inappropriate for that particular member. They're an inappropriate rate, they're at an inappropriate level. So these are claims that are being avoided on the front end so that we don't have to do an investigation on the back end. Reasons for denial are really a national standard. They reflect the best practice in the insurance industry for claims processing. And one of the top reasons for claims denial for all three MCOs, if you go to page 33, is a duplicate claim. So for Amerigroup, for example, that's their #1 claim denial reason. For AmeriHealth, that's their #3. And for United, that's #4. Providers are able to see their claim denial reasons on their remittance advice when they submit those claims electronically. So they should be able to have a very quick response to those claim submissions and know exactly why those claims were denied. All right, skip through the rest. The claims information, in case you want to ask questions later. On page 37, a couple of notes I want to make about the utilization of healthcare services reported. This type of data is going to go through ongoing validation efforts. I think that we have pretty wide variances when you look at this table and how the managed care organizations are reporting how they've reimbursed claims. We're investigating as to whether or not that accurately represents the number of claims that they've reimbursed or whether or not we have a data reporting issue. So each one of the managed care organizations buckets their providers and their services a little bit different. So we're digging in to make sure that they've used the proper parameters to pull this information. Again, I do want to note that this data is reflective of a point in time. So as more claims come in, as rate adjustments happen, these figures will change. On page 38, we have utilization of value-added services. As this report reflects, the early months of this transition to managed care have had a pretty low adoption rate for the value-added services within the managed care organization. That said, we are making sure and digging in to ensure that each one of the managed care organizations are properly advertising these value-added services, that they're providing education and outreach to members that they think would benefit from these value-added services, and that there's no potential gap where a member could benefit. Right, page 39, we have the network adequacy and historical utilization report. Again, this is a measure of the percentage of assigned members whose current providers at the time prior to managed care enrollment are reflected in their managed care provider network. We continue to report this to the Centers for Medicare and Medicaid Services. This, as you probably remember, was a big component of how CMS determined the state's readiness to transition to managed care. This is a reflection of not the most recent report that we've received, but the latest report that we received within Q4 of state fiscal year 16. Moving on to page 41, we have our traditional geo-access time and distance standards, provided links to each one of the managed care organizations' geo-access reports. We review these reports on a regular basis to ensure that any gaps in time and distance are reflective of natural gaps in coverage that just exist with Iowa Medicaid, period. At this time, we feel comfortable that the managed care organization's geo-access is within reasonable expectations, but we're continuing to work with other state agencies and the managed care organizations to expand networks and to grow workforce in areas where possible. One thing to note is that within the contracts, the MCOs, due to these just natural coverage gaps that exist within our workforce landscape, the MCOs do have the ability to seek an exception to those traditional time and distance standards. Moving on to page 42, we get into prior authorizations. Again, we've broken out the medical and pharmacy prior authorizations so we can get an accurate reflection of both. We don't want information to be skewed by the different processes that each one uses. So for the standard regular prior authorization requests, we have the standard that they have a disposition within 7 days. We see that 100% standard is not being met by AmeriGroup and AmeriHealth. And then for the expedited prior authorization request, we see that AmeriGroup hasn't met the 100% benchmark. We are working with both of the managed care organizations to ensure that those numbers go up. And in fact, for July and August with AmeriGroup, we've seen great improvement so far. For pharmacy, the requirement is that those prior authorization dispositions be completed within 24 hours of request. We see that AmeriHealth and United are meeting that 24-hour benchmark. AmeriGroup is at 95%. Again, working with them on processes to improve that. One thing I do want to note on page 45 is when you're looking at the pharmacy prior authorization submitted status, these are dispositions at the end of each month. So this is where they are at the end of each month. When you look at the number approved and the number of modified, what I do want to point out that ultimately the modified include approvals as well. They've just altered. So I'll give you an example. A member might go in to refill their prescription, and they can only fill it for 30 days rather than 60 days due to some maybe potentially narcotic laws that we have in the state. So the managed care organization will seek to shorten that time to the 30-day, the appropriate fill time, and then get that prescription to the members. So ultimately, the modified really isn't approved. It's just shortened up or adjusted to make sure that it's within the proper parameters. Page 46. Encounter data is a very important thing to the state. It's basically a reflection of all of the claims that have been paid by the managed care organizations, and we're getting that data today. This measure of 99% encounter data meeting DHS IT acceptance standards, that's just meaning that it's getting in the door. We are housing it within the DHS system. Ongoing, though, we have multiple vendors that are helping us validate it from different perspectives. One from the perspective of capitation rate development. Another perspective is from a program integrity perspective, and also just making sure that it has all of the required components, that there's not any type of skew in how they're reporting certain diagnostic codes, things like that. At the bottom of page 46, we have the value-based purchasing enrollment percentages. As you recall, one of the requirements within our contract was that each one of the managed care organizations ramp up their value-based purchasing contracts to 40% in 2018. So since we're in the early stages of this managed care program, we expected it to be pretty low still. All right, page 47. We have Jean Slaybaugh here, our Chief Financial Officer, to give some more information about the medical loss ratio and the program cost savings information that's in this report.
Hello. The information on page 47 and 48 is, as Liz said, the financial information for the MCOs. We have pulled the medical loss ratio and administrative loss ratio information from the statutory filings that the MCOs are required to file on a quarterly basis with the insurance division. We've included a bit of extra information in this report. You see quite a bit of narrative, but we wanted to make sure that you had comprehensive information to understand why you may be seeing some of the variances in the data that you're seeing. We're not surprised that the MCOs have reported a loss in the first quarter. It's not uncommon when an MCO enters a new market for them to experience a loss. We expect to see significant improvement in financial performance over the 5-quarter period in the first contract year. Remember that we have a flat capitation rate for that period, but the plan's experience in the market will improve over that time frame, and we do expect to see their financial performance improve as a result. We also want to point out that there are some factors that can contribute to variances between the plans that have not been adjusted for in this report. We will, in future quarterly reports, work with the MCOs to make adjustments for those factors so that the ratios are more comparable across plans. One of the things that we have coming up is risk adjustment. I think we've talked with you about that before. Risk adjustment, while we have one capitation rate now for each rate cell, risk adjustment looks at the relative acuity or morbidity of the membership with each of the health plans, and will make a budget neutral risk adjustment to each of the rate cells for each of the plans. So they effectively will then each have their own rate for each rate cell based on the morbidity of their membership. We know that one of the plans has made an assumed adjustment in their statutory filing for risk adjustment, while the other 2 plans have not. So that's an example of things that can cause variation in